MEHTA, who's a director of the Kesubai Mehta Eye Hospital, Rajkot. And he's going to show us something, another very interesting video. I mean, hats off to all my speakers for bringing in so many variety of cases. So let's hear from you, Dr. Ajay.
Hats off to you, Chitra, for bringing all of them.
Yes, good evening, Chairman,
Yes.
all the moderators,
Yeah.
and dear doctors. Before I begin my presentation, I would like to thank Dr. Chitra for inviting me here and for bringing the AIOS to such great heights.
And our association goes to so many more years when you were so
Yes.
young, no? Yeah.
Yes, Madam, you were my junior.
Yeah,
I was learning FECO and then you were learning EC.
Yeah, I know.
But times change, you know. Right. So here is my presentation, and are you seeing the screen?
Yes.
Okay. This patient was referred by a colleague for a lens that had decentered on the first postoperative day. Actually, during the end of the surgery, the PC had given way while the lens was being dialed, as it is a toric lens. And then, because the anterior vitreous phase was intact, he had left the lens as such, and to his surprise on the next day, he found that the lens was shifted to the nasal side. So now I've taken up the patient for surgery in an attempt to recenter the lens. The side ports open up easily and the anterior chamber is thus formed with cohesive viscoelastic and local anesthetic. After that, I now try to make a bold attempt to recenter the lens with the help of a broad-based spatula. So I gradually pull the lens towards the center, and by doing so, one of the haptics prolapses into the anterior chamber. But because the lens has centered and there is adequate support of posterior capsule in the periphery, I again put it back into the bag and try to finish the case. Do a vitrectomy of the anterior vitreous. All this while the lens is in its place, so I think the surgery is over. But as I remove the irrigation, I find out that the lens has now started again shifting towards the nasal side. So I form the anterior chamber with the viscoelastic again, and then from the lower port I introduce a side port spatula to do what is known as the reverse optic capture. So here I slide the spatula underneath the lens and then gradually bring the lens, only the optical part, in front of the anterior capsular rim, and with a smooth maneuver I could achieve that. Now, because I had constricted the pupil, it has also captured the pupil. So in the next step, I am now going to introduce spatula from the superior side port, and then I will gradually release from one side, that is the inferior side. The pupillary capture is then released from the inferior side. Once this has been achieved, I then go towards the inferior port and release the superior capture, and the lens still remains in front of the anterior capsule while the optics are in the front, the haptics are in the capsular bag. In this way we are preventing any uveitis glaucoma ephema syndrome. With this we come to the end of the surgery, and this is the picture at the time of hydration. On the follow-up you can see that the lens is very snugly in its place and the capsular axis is in the square form. The toric IOL is horizontally placed as desired. Thank you for your kind attention.
Wonderful, Dr. Ajay, very gracefully shown, because this is a uniplanar design of these aspheric IOS. So the challenges
Yes.
of a reverse optic capture you've shown beautifully well. But
Thank you.
supposing this had been a larger rexis, a little eccentric rexis, could you have done a reverse optic capture? Is one question to you.
No, so
Yeah.
now luckily only the day before I was discussing with a friend about what will you do when a toric IOL is put and the posterior capsule is ruptured. And so I had seen some articles about reverse optic capture, and I was so enthusiastic to take up this case, So I told my friend, don't worry, let me try. And the initial steps I tried without doing that capture. But then this step of putting the spatula behind, I read, and then I did carry out. And let me tell you, it's a very easy step. If the capsular axis is smaller than the optics.
Should be smaller than the optic. Any challenges in dialing the IOL to be in the same axis?
No, that's how the rupture happened,
Yes, I know.
The previous surgeon was trying to dial the lens to 180 degrees. He had put it at maybe 30 degrees, and so he was trying to rotate it. And at that time, he pulled the entire posterior capsule with it, it subluxated. So that's why with this single piece IOLs, we require much more dexterity and much more patience, at least at the end.
Would there be any change in your post-operative medications in spite of the fact that the haptic is there in the sulcus? Would you want to do anything differently, or would it be just the same?
No, because the haptics are the one which I had fault every time. The haptics are the one that cause the uveitis, glaucoma, hyphema syndrome. And that's why this technique has been devised. It is even published in the JSCRs.
Yes. Any experts, your opinion, all four of you, anything to add?
Can I add something?
Yes.
I think it's a beautiful video, Ajay. Fantastic demonstration. The only thing is reverse optic capture in a single piece, especially also a toric lens, is not easy job. You made it look easy, but it's not easy. What I do normally is I do it both the edges of the optic. I bring it simultaneously up. I don't bring one side up and then other side will go back. So I do make two side ports on either side, and then introduce two spatulas, two second instruments. And once I know the haptic is in the back, and then bring the center of the optic up and capture it in this thing. So what happens is, that the entire optic will come up, because the regular optic capture is easier because it's the other way around. Okay, this is because you don't have angulation. It's a planar lens. So it's a planar lens, so difficult. So we make sure the optic is there, the haptic is there in the back, then bring both the optic, both the sides, that is the sides of the optic, up simultaneously, and then making sure that you have a good viscoelastic in the anterior chamber, cohesive viscoelastic, and then it makes life a little more easier, I feel, but still it's difficult.
Yes.
The rexis has to be small.
Yes, but I hope we don't face this situation very often, So.
Yeah.
No, but this is a video to be kept in mind for future use for any of us. Dr. Ramurthy, Dr. Kapil, Dr. Rohit, anything to add?
I think very nice video, Ajay. Difficult situation which you have sorted out so nicely. I didn't, just a couple of comments in the sense that one is, I didn't see any digital markings over there. I suppose you had a digital overlay to guide you on the positioning of the lens?
No, it was not that, because this patient was sent by my friend, by my colleague. So we just had the desire to center the lens. But then
final positioning of the lens.
180.
Yes. 180.
Okay. Anyway, it worked in your hands. I would have ideally, whenever I'm doing a second time surgery on an intraocular lens or even a toric ICL, always have the marking or the digital overlay so that the exact positioning is there. Second thing is you did it so elegantly, but still in this situation with such a large PCR, at the end of the surgery, at least I would have put in some tramstone as state to make sure there's no vitreous trans. Sometimes you are surprised that there is something over there. And
No, I did the vitrectomy and the trams in along everything.
tramstone was shown, right? Maybe
Yes, it was vitreous was there, and I did a vitrectomy also.
okay.
But because it is a 4 minutes video, I had
right.
to.
And the other comment I had was that, I have faced a similar situation. You could create a reverse optic capture because where the haptics had to be located, the capsule was intact, and you could bring the edges of the optics up. I have had a situation where I did not have enough support by the posterior capsule in the area where the haptics were to be located. And because it was again a toric lens, I did not have a choice of rotating the lens in a different position. So basically what I did was to bring the haptics into the sulcus and create an conventional optic capture. I know the thick haptics of the single piece lens should not be left in the sulcus, and it does create problem. But I have shown it, and I have almost a 6-month follow-up of these patients, kept him on steroids for a longer period of time. Both his correction as well as his, the eye has been pretty quiet. So obviously this is not something we recommend, as was discussed. In these planar lenses, to create any kind of optic capture itself is a difficulty. But sometimes when you're faced with these situations, you have to adapt to what you have, and it does work out.
There's a small thing that I would like to differ. Is reverse optic capture is usually done when there is a posterior capsule rent. So even if there is no support for the haptics, the optic fits so nicely in front of the anterior capsule that we did not then worry if the entire posterior capsule is absent. So there is no support required for the haptics. This is the optic which holds it lifetime. And as I showed in the postoperative pictures, even a routine toric IOL does not stay so well, and this style just fixed over there.
Rexis needs to be really small for that to happen. Yeah.
Small enough, yes.
And to get the optic out of a small rexis, no, it's a very well done.
I'm not sure about that, Ajay, because what Ramurthy is saying is there is a point, because if you lose the rexis in the axis of the toric lens, then lose the posterior capsule, you don't have support for the PC. How will the haptic stay there?
And if the if the AC gets shallowed post-operatively, this optic could go behind also.
Yes, the optic goes behind, then you have lost the lens.
No, I had a situation where while I was injecting the toric lens into the bag, the posterior capsule was damaged, and there was no support at all for the haptic to rest there. So I had to, it was a fairly high cylinder that I had a digital overlay. So basically I had no other option because I find rexis. It was actually a LRCS case. And then I just brought the haptics up and created a conventional optic capture. I know that the haptics, a single piece of the haptic should not be left there.
No, that's the reason. We're not talking about that, Ramurthy. I'm talking about Ajay's contention.
No, that's what I'm saying. So I'm not very sure that when you don't have capsular support in the area where you're leaving behind the haptics, at least at the initial period, maybe once it gets fibrous, there'll be enough support, but whether it will remain undisturbed right on the table.
Dr. Rohit, do you have anything to tell?
Somehow I don't buy the idea that if the posterior capsule is not there, you do a reverse optic capture. Because if it is not there, I somehow do not, I beg to disagree with Dr. Ajay for that matter, because, second point is that what Dr. Ramamurthy said, that he placed the haptics in the sulcus. For all the listeners, I would recommend, as he has also said, we should definitely not try to put the single piece haptics in the sulcus. Dr. Ramamurthy, you agree with me? It was a special case where you did.
Yes.
I had a
lot of toric lens inside. Yes.
Yeah, I had a lot of concern. Supposing I had a PC rent during phacoemulsification itself, I would not have injected a toric lens at all. This is a case where the lens had already been introduced. Patient had expectations. I thought, let me, instead of cutting the lens and bringing it out, let me see whether it works out. I'm not at all saying haptics can be left in the sulcus, thick haptics. But I did this, and at least in the limited follow-up I have of this patient, he seems to be doing all right.
You need to have a very close follow-up of.
Do you do a PI for these patients, Ramurthy?
No, I didn't.